Hi there, I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. I'm a medical oncologist, and welcome to this PrecisCa GI tumor board. I am joined today by a very esteemed faculty, and I'll start with introductions. Dr. Catenacci.
Hello, I'm Dan Catenacci. I'm a GI medical oncologist and director of the GI oncology program at the University of Chicago.
Hi, I'm Marty Weiser. I'm a surgical oncologist at Memorial Sloan Kettering Cancer Center in New York City.
Hi, I'm Darren Keyes. I'm both a interventional and diagnostic radiologist at the Piedmont South Imaging Center, covering 2 hospitals southwest of Atlanta.
Hi, I'm Pritesh Patel, a radiation oncologist focusing on GI malignancies at Emory University in Atlanta.
So here we have a 58-year-old gentleman with a 1-year history of symptoms and workup, but again delayed because of COVID. The colonoscopy now revealed a villous, ulcerated, partially obstructing lesion in the mid-rectum, just proximal to the first rectal valve, where the mass was found approximately 10 centimeters from the anal verge. The biopsy revealing a moderately differentiated adenocarcinoma, microsatellite intact, imaging revealing a rectosigmoid lesion, which is staged clinically as a cT4N1M0 lesion. So I think this is a fairly similar discussion, right? Should total neoadjuvant treatment with short course radiation therapy followed by long course chemotherapy and then surgery be offered, or would longer course chemoradiation then surgery be favored? Is colostomy sparing surgery an option? And as COVID cases decline, what is the best way to encourage patients to undergo cancer screening and have a workup for suspected cancer? So this patient presented with hematochezia, diarrhea, cramping, abdominal pain, and weight loss. ECOG performance status is 2. This patient's past medical history is significant for GERD, reflux disease, arthritis, depression, and BPH. The patient is currently not working, but was working setting up concerts and conventions, doesn't smoke or drink. As far as family history, the mother has a history of leukemia. So data we have available from April 2021, a colonoscopy, which revealed a villous and ulcerated, partially obstructing and circumferential large mass in the rectum, just proximal to the first rectal valve. It extended from 10 centimeters of the anal verge to approximately 20 centimeters from the anal verge. The biopsy revealed a moderately differentiated adenocarcinoma. MSI was intact. The MRI of the pelvis notes a mass extending from the mid-rectum to the level of the rectosigmoid junction, measuring 6 centimeters circumferentially, involving the entire rectal wall, with the lower end of the mass measuring approximately 9.5 centimeters from the anal verge. The tumor extending into the adjacent mesorectum with peritoneal involvement anteriorly, and a right 0.5 centimeter internal iliac chain node, which was suspicious. Here we have the MRI.
Sure. So we've got, these are all, the 4 images on the left are axial T2 weighted images. The 2 images on the right are sagittal images. The one on the top is a T1 weighted contrast enhanced image, and the image on the bottom is a T2 weighted images. We'll start with the one on the bottom. It's got markers in there showing kind of measurements of the tumor. You can see there's a large circumferential, nearly obstructing mass in the upper rectum near the rectosigmoid junction. You know, it's about, like, as described, about 9 centimeters from the anal verge. The axial T2 weighted images, you know, show these findings. The extension into the mesentery is not well depicted in these images, though the top right image, you can tell that this is kind of a more aggressive appearing mass. And I think you get a glimpse of that suspicious appearing lymph node on the top right in the internal iliac chain, just adjacent to the mass. You know, all these findings are pretty much concordant with what was described above.
Okay, thank you. So now we come to the clinical decision making. Should total neoadjuvant treatment with a short course of radiation therapy followed by long course chemotherapy and then surgery be offered, or would long course chemoradiation and then surgery be favored? And I'd like to group that question with this first one is the second question, colostomy sparing surgery an option? So again, Dr. Weiss, I'll start with your take from the surgical approach.
So generally, we often look to the anterior peritoneal reflection to delineate upper from lower rectal tumors and those that would have benefit from pelvic radiation. Generally, mid to low tumors benefit from radiation where upper ones do not. Now, this lesion is quite bulky, so it's a little bit different. With regard to the lateral lymph node, although it is not greater than 7 centimeters and often used cutoff, it does look suspicious. It is a little bit odd because most of the data indicates that lateral lymph nodes are involved for tumors less than 7 or 8 centimeters from the anal verge. So I would still question that lymph node, but we do need to keep an eye on it. We can't ignore it. But as the Foxtrot trial has showed us, there is a role for neoadjuvant chemotherapy before upper rectal cancer resection or rectosigmoid resection to achieve a margin negative resection. And I think that's the goal here. So I would favor upfront chemotherapy and then reassess to see if you need radiation or not.
And in an ideal scenario, could this patient be spared a colostomy?
I think so, yeah.
So a good response to neoadjuvant therapy, which will come up with that optimal regimen, could potentially spare this patient a colostomy.
That's right.
So now the question is, what is the optimal upfront regimen? And this time we'll start with radiation oncology. Dr. Patel, is there an absolute need for chemoradiation in this patient? What is your assessment?
Yeah, I'd agree with what Dr. Weiser just mentioned, which is if this is a sigmoid cancer extending down into the rectum, and we treat it as such, I agree. There's not necessarily a role for radiation in that setting. If we call this an upper rectal cancer, at our institution, this is one of the cases where we almost certainly would give the chemotherapy or a TNT type chemotherapy first, and then reassess. I don't think we have yet the results of the randomized study looking at omitting radiation, maybe in some of these rectal cancers with an excellent response to chemo, but that, in these upper rectal tumors, that's certainly enticing. And, from my perspective, in terms of how we deliver radiation here, I think certainly we're going to help in the presacral space. This tumor is bulky and is sort of invading the presacral space there, but it's also, in front of the sacral promontory, and that really means that you're going to get a lot of intestinal exposure, which is going to increase the toxicity of radiation. And so, yeah, I agree with what Dr. Weiser said. Start with systemic therapy, optimal systemic therapy, reassess, and if there is a way to avoid radiation in this case, I would favor that as well.
So I'm going to throw a question back to our surgeon, maybe Dr. Kreis. I mean, and you brought it up, Dr. Patel. Why is there a debate about whether this is sigmoid or rectum? Do we not have all the data here that we need to make that distinction, or it's just very close?
Well, I think it is right in between. I think it's likely an upper rectal cancer, and if we could scroll through the images, I'm sure we could try to figure out if it's above or below the anterior peritoneal reflection. But I wouldn't really call it a mid to low, that's for sure. So I think it's a gray zone.
Dr. Kreis, did you have anything to add to that, or?
Yeah, on the single image, it's a little hard to tell. But again, if we could scroll back and forth, you might be able to make that distinction a little bit further. Sometimes, in endoscopy, a conversation with your gastroenterologist can help kind of, delineate those things out a little better as well.
And so unlike a lower rectal lesion where I think the discussion about chemoradiation and chemotherapy, TNT is more relevant, Dr. Catenacci, what would you recommend as far as the chemotherapy regimen in the perioperative period here?
Yeah, well, you heard the Foxtrot study, which used an induction or neoadjuvant FOLFOX chemotherapy. Some of the criticisms of that study is that many patients are getting therapy that may be lower stage and you didn't know that, and they wouldn't have gotten any adjuvant therapy. But in this particular case, that I think is what that study was designed to do, as you heard Dr. Weiser, in the sense of downstaging and enhancing R0 resection rates. So we would certainly start with FOLFOX. I think FOLFIRINOX might cross my mind, given what we know in terms of the benefit of FOLFIRINOX. I noticed this patient, though, had a performance status of 2. I didn't catch why, but, you know, is it from disease and he could use response, or is it from other comorbidities? Maybe I'd avoid FOLFIRINOX, but certainly FOLFOX for sure. And then we would reassess. And, you know, in the setting of the situation where there wasn't an adequate response and it was still thought that an R0 resection was not achievable, then certainly RT would be brought in at that point. And so, on the other hand, if you had a dramatic response to the neoadjuvant chemotherapy, then I think we would just go on and proceed, given that it's high up like this, and evaluate the results at that point.
And you would, as you stated, most likely FOLFOX for 4 cycles, restage, presumably go to surgery at that time, and then continue with chemotherapy after surgery?
Yeah, typically what we'll try and do is get a good 6-month course of therapy in.
Total.
And so again, we would take that in 2-month stages with reassessing. And if, again, there was some response, but maybe not enough, and we thought we could achieve more, we might do another 2 months and then reassess, something like this. But ultimately, we would want a approximately 6-month course of therapy when you add the pre and post therapy parts.
And would you consider any role for biologics here? Bevacizumab, or we don't know the KRAS status, I don't think, but.
Right, that's an interesting point, and you know, in this perioperative setting, I think that targeted therapies have not been sort of demonstrated to sort of provide any benefit, as opposed to, say, in the metastatic setting. I probably would avoid a biologic here, even if RAS wild type, just given what we know from the new EPOC study, where patients with oligometastatic disease that got FOLFOX or FOLFOX with anti-EGFR therapy, actually the EGFR therapy did worse, and potentially because it's driving resistance mechanisms early and selecting for more resistant disease. So in the perioperative setting where there's no evidence of metastatic disease here like this, I would probably shy away from biologic therapy.
Could I ask about the option between CAPOX and FOLFOX in this setting? Do you have a preference? I do see both given.
Yeah, I think that ultimately FOLFOX and CAPOX, the debate will go on. Generally, they're considered interchangeable. You know, that said, usually in studies that have been head-to-head, CAPOX tends to trend in favor to, you know, even in the IDEA studies with 3 versus 6 months. The CAPOX tends to, you know, outperform FOLFOX, but if you give 6 months of FOLFOX, then you're okay, as opposed to 3 months of CAPOX. So, you know, that said, capecitabine does come with a little bit more of a toxicity profile, hand-foot syndrome, etc. And, you know, ultimately, sometimes we describe the pros and cons, the risks and benefits of each one. And a patient says to me, I just want to get this cycle over with. Give me the thing for 2 days on the pump and then leave me alone, as opposed to taking 4 pills twice a day for 2 weeks. And then the next patient's a little different. So you can personalize that to patients' wishes, because ultimately they are considered relatively interchangeable.
Yeah, and I think I would agree with that. There's also getting the patients to take the prescribed dose of capecitabine, right? Versus it's IV, it's in, you're done, versus the 2 weeks of ongoing, you know, dosing.
Right.
So
can I ask a question to
Sure.
Dr. Weiser? Would inclusion of radiation in a case like this alter the need for even a temporary ostomy?
Yeah, thank you. I think that's an excellent point. Everybody has a different, you know, set point of when they will use a diverting stoma. For me, radiation sort of does require bringing up a stoma. I do think it affects healing a little bit, so I would be in favor of it. For anastomoses that are sort of less than 5 or 6 centimeters from the anal verge, no matter what, I would generally divert, and most people that get radiation, I would divert. But it is a discussion with the patient to see what sort of risk they would be willing to take.
So I think in this case, the tumor board has a fair consensus that this lesion is a high rectal, low sigmoid lesion, and we would favor systemic chemotherapy up front, either FOLFOX or CAPOX, probably for 4 cycles, assessing response, and most likely at that time going to surgery, at which time there is no expectation that an ostomy would be required, that we could avoid that safely. Postoperative pathology would be assessed, but the oncology opinion would be to finish a complete course of chemotherapy with probably a total of 6 cycles of FOLFOX or CAPOX. Should the patient not have an adequate response to neoadjuvant chemotherapy, then perhaps a discussion with radiation at that time would be appropriate.